Okay, thank you very much for welcoming here. It's great to be here. I was involved in this society right in its early days, and I haven't been involved for a very long time, so it's very nice to see quite a number of familiar faces. The conference organisers very kindly put me up in the Marriott Hotel in Five Ways, Birmingham, and I looked out of the window and was rather thrilled to see a familiar sight. This clock was actually put up for my great-great-grandfather, who was the first coroner of Birmingham in about 1838, I think, and he was also professor of forensic medicine here in the medical school, so that was very exciting for me. There he is. He looks a bit formidable, but apparently he did great work for the poor, and he was also very interested in mental health, so I think he was probably a good guy. Okay, so now on to my talk. I owe Muir Gray a debt of gratitude for this formulation of what we're trying to do in priority setting. He has articulated it this way, that we're concerned about technical value, we're concerned about allocative value, and we're concerned about personal value. And you're going to hear a lot in the conference about technical value and allocative value, so I'm not going to talk about them. What I want to do is to suggest to you that personal value is something we need to be thinking quite hard about when it comes to priority setting. Now, on the day I was preparing this talk, these were the newspaper headlines. It won't be news to anybody from England that we're in a bit of a crisis at the moment. Priority setting has become a very, very real and practical problem. And around the country, there are things called service STPs, Service Transformation Programs, is that right? There are 44 areas, geographical areas, who are desperately trying to think, how are we going to square the books? How are we going to get the greatest value out of NHS resources? And there, Nigel Edwards at the Nuffield Trust has been looking at what their plans are coming up with, because of course they're actually working incredibly fast and in a rather secretive way at the moment. And the list here, I won't go through it, it will be very familiar again to all of you in this country and probably in many other countries as well. The usual kinds of things, fiddling around with the supply side to see if we can organise things better and get more blood out of the NHS stone. And one of the problems is that the public has not been much involved at all in these discussions. And that's partly, it's not, I don't think, because of a lack of will. I think it's much more because they've been told to come up with plans by October, and there is very little time to do that. But this is a big problem. If we don't have these discussions with members of the public, then what we end up in is a kind of problem situation where people feel that they're losing something that they value, and they'll be out on the streets to demonstrate against any changes that are proposed. So not having patient and public involvement in priority setting discussions is a major, major problem. And what I want to suggest to you is that we need to change the terms of this debate. The public must be brought along with it, and they must be encouraged to take a more sceptical look at what's on offer, at what we're spending our money on. Here's an example of the case that more is not always better. This is from the NHS Atlas of Variations. It shows on the left the primary hip replacements, the rate of primary hip replacements. You can see a lot of variation in the rates between different geographical areas. And on the right, you can see the same atlas with the amount of health gain, because we now measure health gain using PROMs, using the EQ5D. And you can see there's no relationship between the two. So those areas which do the most hip replacements do not report the most health gain. That's important lesson number one. that the public needs to understand. What they also need to understand is that some of the things we're doing actually produce very, very small benefits. And a classic case in point is breast screening, a very popular program introduced after much political lobbying. But in fact, it has no impact on all-cause mortality. And the problems, the risks of breast screening, of course, are that you will have unnecessary investigations. So breast screening is, I mean, there may still be a case for continuing the program, and I don't think, as far as I know, anybody's suggesting not continuing it, because, of course, it does provide reassurance, but it provides false reassurance to many women, and many women go through unnecessary investigations and have diagnoses that actually wouldn't have caused them any harm if they'd only known. So they need to pay help to make informed decisions. And of course, people considering elective interventions also have difficult trade-offs to make. They may have trade-offs between lifestyle, medications, various devices and surgery. And of course, the risks of those interventions, they go up with the effectiveness of the intervention. Again, not an argument for not doing it, but an argument for ensuring that people understand what they're getting into. And of course, we're now seeing more and more commercial pressures. This is an advertisement for screening. You can go and have yourself privately screened with no requirement that anybody sits you down and helps you to think through what you'll do if something is discovered when you have a CT scan, which you've probably paid a lot of money for. And this is the same thing for DNA scanning. So you can have, this is 23andMe, you can have your scan done, and all sorts of possible future illnesses may be detected. These companies are working now in this country and in many other countries and generating more demand. So the answer is we really need to help patients and the public make informed decisions about these issues. And indeed, if we want to engage the public in priority setting discussions, the best place to start is with their own care. People need to understand that more isn't always better, that harms are caused by medical interventions and they sometimes outweigh the benefits, that unnecessary care means unnecessary risk and cost, and means that other more effective treatments have to be foregone. So efficiency is better for everyone. This is not the message that is being put across in the newspapers. So if we want to challenge this, we have to get much, much better at informing people. And I feel very strongly that the best place to start is with people's own individual care. We know that people do want health information. Most people want more information than they get, and many people feel uninformed and ill-equipped to make decisions about their health. When I worked at the Picker Institute, I used to run we used to run the national patient surveys for the NHS, and we've ever since these started in 2002, these are massive surveys right across the country, every institution in the country. This is the inpatient survey. We've always asked this question: were you involved as much as you wanted to be in decisions about your care and treatment? And you can see from this that yes, maybe it's getting slightly better now, but it's still nearly half of patients who've been in hospital say they would have liked more involvement and more information about their care and more involvement in decisions. And many people we know spend ages searching for information. And of course, now you can find masses of information on the internet. But it's very hard to know whether the information you're finding is reliable. And studies have shown that the kind of information you'll find if you do a Google search tends to be very positive about the benefits of medical care, and risks and side effects and the downsides tend to be glossed over. So information at base is very important, but it's not just information people need. They also need to be engaged in decisions, for somebody to be interested in asking what their priorities are. Here's an example. It's an American study, actually. Women with breast cancer who face a choice of, this is early stage breast cancer, it's been diagnosed, and they face a choice of mastectomy, removal of the whole breast, versus lumpectomy and radiotherapy. And that's quite a common choice. It's known that the outcomes in terms of mortality are more or less similar, so it's a real choice. And it depends a lot on how you feel about the cosmetic result, about the burden of treatment, and so on. This study, they asked breast surgeons what they thought most women's priorities were in making this decision. And you can see that most of these doctors thought that most women would want to keep their breast. In other words, they would opt for lumpectomy. Most also thought that length of life was crucial, and most also thought that the cosmetic result, looking natural without clothes, was really important. They then asked the patients who were being treated by these doctors what their priorities were, and you can see there was really no correlation. The women were much more evenly spread. People, not surprisingly, had different priorities. So some people very clearly wanted lumpectomy, but there were many women who, somewhat to the doctor's surprise, thought that mastectomy was the better answer. So the simple message here is you cannot assume what people want unless you ask them, unless you have a good discussion with them. And we call this kind of good discussion shared decision-making. And to understand this concept, you have to first recognize that there are at least two important sources of knowledge or expertise in any consultation. The clinician is expert, or at least we hope they are, in diagnosis, in the causes of disease, the likely prognosis, the treatment options and outcomes. But the patient, and only the patient, knows what it's like to experience the illness in their particular social circumstances. They, and only they, know about their attitudes to risk, their values, and their preferences. So you can't make a good decision without drawing together both these sources of expertise. There's a definition of shared decision-making: clinicians and patients working together to select tests, treatments, or support options based on clinical evidence and the patient's informed preferences. So in order to be involved, what people need to know is, what are my options? What are the benefits and possible harms? How likely are these benefits and harms? And how can you help me make a decision that's right for me? And this has to be done systematically, and there's been a lot of research now over many years into how to do this well. And essentially, it involves good evidence-based information presented in a way that patients can understand and that makes sense to them. A process of supported deliberation, so that means real skills for the clinicians in how to communicate these kinds of trade-offs. And finally, a system for recording and acting on whatever the clinician and the patient agreed. And this is relevant in all sorts of settings. It's relevant for elective procedures, for tests and so on. It's very relevant for managing long-term conditions. It's relevant in health promotion and wellness. It's relevant at the end of life. It's relevant for most important health decisions. Patient decision aids have been developed, and there are now quite a lot of these available, including here in the UK, but also around the world, that set out the evidence in a way that it can be useful to patients to make these kinds of decisions. Here's just one example. This is a breast cancer example again, and this uses a computer program, and it sets out, qualitative research was done with a lot of patients, asking them what's important to them, and then those sort of themes were summarized on the left-hand side, and then you can kind of click on the bits that are most important to you, and the weigh scale thing sort of tips and says, you know, it looks as if you're leaning towards, in this case, mastectomy. The idea is you go through that, you think about it, you may discuss it with your family and friends, and then you go to talk to the clinician and make a joint decision. There's a Cochrane review of the evidence on the effects of these types of tools. Now 115 randomized trials in the Cochrane review showing that using these kinds of methods that I've been talking about definitely leads to an improvement in patients' knowledge and understanding, in their perceptions of risk, in their ability to participate in decisions, their willingness to do that, and their sense that they have made the right decision for them. It also, interestingly, seems to have an impact on the uptake of procedures. So here's from the Cochrane review, the rates of elective surgery using these means, and overall they reduced by 20%. So, I mean, we don't know that will be the case in everywhere or for every condition, but it's certainly for those people writing their STPs and desperately trying to work out how to make the money go further, this may help. There's also evidence from another systematic review that use of this kind of procedure, shared decision making, can reduce the use of antibiotics, and of course we know that use of antibiotics, for example, for respiratory tract infections, there's a lot of concern that these are being overused. When you inform and involve patients, they don't necessarily ask for more. They understand better why more isn't a good idea. And this kind of approach has also been used in a number of health facilities around the world, but here's an example from the US. Group Health, who encourage all their patients coming for hip and knee problems, osteoarthritis, to go through a shared decision-making process. And they found, having done this, that this led to cost reductions of between 12 and 21% over 6 months. So informed patients make good decisions, make the right decisions for them, and don't necessarily demand more or feel that things are being removed from them. Now, I imagine everybody here, more or less everybody here, will be familiar with the EQ5D, which is used as the basis for QALYs, which is very much used in, and has been for a long time now, in attempts to do priority setting systematically. The EQ5D focuses a lot on mobility and activity rates. There is also a question about anxiety and depression. But when we recently in Oxford, as part of some work we're doing on long-term conditions, asked people what were their most important issues in managing their long-term conditions, and these were patients with a very wide range of long-term conditions, interviewed using in-depth interviews, they came up with some very different issues that were important. They talked about, for example, the need to feel supported, the burden of treatment. They talked about achieving their own personal goals, which might not be, being able to do the washing up and dress yourself, may be quite different. They talked about isolation and social participation, loneliness. They talked about a feeling that you lived in a safe environment, and so on. So for me, that suggests that we need to look again at how we're calculating benefit when thinking about how to allocate resources. We really do need to recognize that we're now in a situation where the majority of healthcare spend, it goes on people like this, people with long-term conditions. It's not younger people who have activity problems in the main, although of course that's also very important. Somehow or other we have to expand our way of thinking to encompass these kinds of issues. So just finally, the kinds of measures what I'm suggesting that we look at are these. So not abandoning the ones that we've been measuring for many, many years, but adding things like the impact of the condition, the quality of communications, the involvement in decision-making, and so on. So just to summarize my points as simply as possible, firstly, I've been arguing that individuals' goals and values are important. They, as well as looking at resource allocation in the traditional ways we've done, we really need to look at personal value. We also need to help the public be involved in these discussions and debates. And in order to do that, we need to help them understand the limitations of medical care, to develop a skeptical view rather than assuming that more is always better. And the best place to start is where it really matters to individuals, and that is with their own care. So it involves changing the kinds of conversations that happen in clinical practice. And I hope I've shown you enough evidence to persuade you that using this approach, this shared decision-making approach, leads to more appropriate care, and that it has ramifications also for the kinds of outcomes we measure when we look at the effectiveness of medical interventions. Thank you very much. Ready to go? Yeah? Yeah.
Thank you, Joe and Iestyn and the organising committee for inviting me to be part of this opening session today. I'm delighted to be here and looking forward to a great conference. I'm going to talk about what matters to people from a societal perspective, so thinking about populations and preferences. There are straightforward arguments for why societal values might be relevant to priority setting and questions of resource allocation in health. As the payers for the health system, in publicly funded health systems through taxes, and as the patients of the future, the people who will benefit from treatments or not benefit from treatments that are not provided, it seems reasonable to suggest that their views, our views, are relevant. Just to say something about where I'm coming from in all of this, my background is kind of in UK health economics, if you like, and so I've grown up with a dominant discourse which is around cost per quality as a way of looking at resource allocation or priority setting decisions through a cost effectiveness lens. And at least since the 1980s, the debate around using QALYs has touched on this issue of whether or not a QALY is a QALY is a QALY. So we're all QALYs to all different types of patients, coming in different forms of equal value to society, or are some QALYs more valued than others? And my sort of journey in this over the last 10 to 12 years is through some work going back now on the social value of a QALY, where we looked at the monetary value of a QALY and relative values for different types of QALYs. And so this was a UK-based study followed by a European study, both of these collaborative projects led by Cam Donaldson. More recently, I've been leading on a piece of work funded by the Medical Research Council, looking at societal perspectives and the relative value of life extension at the end of life, so extending life for people who have short life expectancy, and I'll come back to that work later on. What I'd like to do in the next 15 minutes or so is to start just by making a note of terminology and methods to do with societal values, social values, preferences, viewpoints, and these words that we use often interchangeably. And then go to end of life as a case in point. So look at that policy in the UK and use it as a way of drawing out some more general points about what we do when we find that societal values are multiple, when we have different ways of looking at something and different ways of valuing something. And I'll finish just by raising a few questions for discussion and conversation perhaps later in the conference, and also some research that I'd like to pursue in the future. So first of all, that note on terminology. When I was preparing this, it was occurring to me that I was using these words in many different ways, maybe in the one presentation. I think what I've tried to show on this slide is on the left-hand side, a more quantitative look at societal values. This might be the way that health economists are familiar with talking about value and preference. So we're interested in people making choice, whether there's an alternative foregone, or whether there's a sacrifice made in order to express the value of some health good or some state of the world. Typically quantitative measures, and I've listed some of those there. So we might go to willingness to pay and use that as a way of looking at valuation, or person trade-off. On the right-hand side of the screen, I think what we've got is a more qualitative approach. So we might also be interested to know about what members of society think in a more narrative sense about some state of the world or about some proposition or policy. And then we'd go to more qualitative methods. But in the middle of the screen, I think some of the most interesting questions lie, whether that's about bringing together quantitative methods with qualitative methods, or about using mixed methods that allow us to use both quantitative and qualitative techniques. And so for me, that has been Q methodology, and more recently trying to design survey methods out of Q methodology studies. So I don't resolve that, I just put it up there as something I think that we do. We use these words interchangeably, and sometimes value is something measurable based on a willingness to pay study, and sometimes it means a moral value. So to the case of end of life then, so many people in this room will be familiar with this, but for those that are not, NICE in the UK has an approach based on cost per QALY, where new technologies compared to old technologies are assessed with reference to a threshold, which is £30,000 per QALY. And in 2009, NICE introduced an additional piece of guidance that said that if certain technologies were for people who were within 2 years of the end of life and would stand to gain at least 3 months of increased life expectancy, then we'd be willing to pay more. And at that time, it wasn't stated how much more, but over time, it seems that £50,000 is what's applied to end-of-life technologies, £50,000 per QALY. Now, I'm not going to go into that in much more detail. There's a great paper by Calypso Chalkadou in Health Economics Policy and Law, if you'd like to read more about kind of what led up to that policy. But I want to draw your attention to the claims about societal value around that policy. So this comes from a paper by Professor Michael Rawlins, then chair of NICE, where he's actually talking about more than end of life in this paper. But this quote says that the Institute recognises that the public generally places special value on treatments that prolong life, even for a few months, as long as they're of good quality. So this is a claim about what is known about societal values. And I would say that at that time, we didn't have robust research evidence on which to base that claim. It wasn't as if there was nothing. I think NICE went to good efforts to try and find out what societal values were. NICE has its Citizens' Council who deliberate these issues, who had a report in 2008 departing from the threshold, part of which dealt with this issue. They had a public consultation and hundreds of people wrote in and said what they thought about the proposed policy and so on. So it wasn't based on nothing, this claim, but I don't think it was based on robust research evidence. And you can see other claims made about other policies that here the Cancer Drugs Fund that make claims about societal values. This is a quote from an interview reported in the BMJ, and the head of the Cancer Drugs Fund says that the relative peace and quiet from other patient groups reflects the fact that cancer has a special meaning in what they are prepared to pay for. So here it's almost the silence of others that is being used as evidence of societal support for something, and I think even less robust evidence to support that claim. So what have we as researchers provided that would help organisations like NICE with problems like this? So staying with the end-of-life case, what have we learned since 2009? And there's been a flurry of research in the subsequent years, but it produces very mixed findings. In a chapter in this book, Kunal Shah, who's here today, and I know presenting on this later in the conference, so I'm not going to steal any of Kunal's punchlines, I hope. But Kunal reviews the literature on preference solicitation studies and end of life. And what he finds is, in approximately 15 studies, most of which have come since 2009, half of those studies report a positive premium or a positive QALY weight for end-of-life life extensions, and half of them don't. So what we've learned is that the evidence is mixed. The work that we were doing was in that same time period, but we were using Q methodology, a mixed methodology, a mixed method to look at what societal perspectives were. So we were interested probably in a more sort of narrative, holistic look at what people thought on this subject. And I don't have time to go into lots of detail on methods and analysis, but the first paper from that project by Neil McHugh and the rest of the team is in BMC Medical Ethics, if you want to read about it or try out some of the instruments on our website. So this will be a very quick whiz through that study in order to make a point about plurality in values. Q methodology involves asking participants to rank order a set of statements. So we gather together a set of statements on the topic in question, and we present them to respondents who place them onto a grid that looks a bit like this. So here, labelled on the left from disagree most to the right, agree most. And they start by placing the statements that they really strongly agree with and the statements that they really strongly disagree with, and work towards the centre until we have a complete rank ordering laid out in what's called a Q sort. And then as Q methodologists, what we do is to look for similarities between people's Q sorts. So we look at the correlations between Q sorts and find those that are similar to each other and that are distinct and different from another cluster of Q sorts. And we interpret those clusterings of similarity as shared perspectives. Here, shared societal perspectives on the relative value of end-of-life health gains. And this is what we found. And in the paper, we write quite a long, detailed narrative about this. I'm just going to give you the kind of headline points. We found 3 perspectives. The first of which was taking a population view, taking a kind of health system view, and recognising that fixed budget, and argues that we should maximise health. So it's a very recognisable kind of utilitarian perspective on healthcare resource allocation. And that means that for end of life, there's no special cases. So these quite expensive technologies that extend life only by a short amount wouldn't be a special case in that view. Viewpoint 2 is quite different. It takes an individual level perspective. It's much more framed around rights and entitlements, and is not interested in cost as a determining argument for why something might not be provided. For viewpoint 2, life is precious, and patients and families might find enormous value in short life extensions. Viewpoint 3 is also concerned with value for money. So in some ways, it's like viewpoint 1, but it recognises broader benefits. So for viewpoint 3, the quality of life and the quality of death are paramount. But there must be a measurable benefit. It's just that that benefit might be something more than maximising life years. So we had these 3 viewpoints, and we looked to design a survey that would allow us to measure support for those viewpoints in a larger population. So this was an in-depth study trying to understand those narratives. Now can we survey people and see how well supported or how common those are in a wider population? And these are the results that we got from an online survey of 4,900 people. The most common you can see is viewpoint 2, so it's the sort of patient choice, life is precious account. And almost half of the sample most agreed with that viewpoint. There's substantial support for the sort of utilitarian viewpoint. 37% of people supported that the most, and about 1 in 10 viewpoint 3. So we can see that there are multiple perspectives in a societal sample. We can see that those perspectives are competing and oppositional. If we look at the quantitative literature on end of life, so these are some of the preference solicitation studies that Kunal reviewed. Here are two that used willingness to pay amongst other methods to look at willingness to pay for life extension at the end of life, so a hypothetical scenario presented to respondents, and compared that with willingness to pay for a non-end of life QALY, same-sized health gain. Both papers found that the life extension at the end of life was on average more valued than the non-end of life scenario, but also found a greater number of real zero willingness to pays on the life extending end of life scenario. So in other words, although it had a higher mean willingness to pay, that was in spite of, in some cases, almost a third zeros, excluding protest zeros, which seems to suggest, again, that we have two groups with competing and different perspectives. So I just wonder whether or not that plurality around this issue that pulls in different directions might go some way to help us understand why in all of those papers we have half the papers saying sort of yes and half the papers saying no. Perhaps the real issue is that the population is split like that and the papers are coming down either one way or the other. Maybe. So I just wanted to pull back then to draw out some more general issues from looking at that end of life as a sort of case study. And I don't think majoritarian approaches are going to get us very far. I think our results illustrate that in a way. And I don't want to say too much about 2 and 3, partly because I know in this room there are people who are far more expert in ethical analysis and in deliberative methods than I am. But I wanted to put them up there as to prompt debate, to prompt conversations, and to say what role societal values. So with respect to sort of ethical analysis, I wondered whether or not there is scope for a critical analysis of societal perspectives. So in other words, if empirical work of the kind that we have done generates these accounts, can we have a critical look at how well they hold together, the logical consistency of those arguments, can they be applied in policy? And with respect to deliberative methods, I wondered whether or not knowing something about societal viewpoints might help us to select participants to engage in deliberative activities. So rather than, by definition, deliberation involves usually smaller groups of people, so we might be concerned about how we select those small groups of people. And rather than selecting them on socio-demographic characteristics, or perhaps on their experience of the health service, might we also be interested in what we know about their fundamental values and the principles that they subscribe to? The fourth point I just wanted to say a little bit more on, because it's where I would like to take some research in the future, and that's to look at the empirical data, the societal values that we elicit in some way from samples of the population, and examine those for consistency and for potential areas of consensus. And I was thinking that might, that looking at societal values or principles in terms of levels might be a helpful way of doing that. So in the Q study that I described to you, those statements mix up, if you like, lots of things at a high level, beliefs at a high level about rights, for example, mid-level applications and operational policy matters, and lower level case or patient-related choices. And I think if we separate those out, we might be able to, using methods that we already have, look to see whether or not respondents who express at the highest level, for example, utilitarian beliefs, are consistently expressing utilitarian preferences at some mid or operational level, and then when faced with choices between groups of patients in the way that we do in things like person trade-off studies. So is there vertical consistency? Not to say that consistency would be the only thing that might matter here, but I think it's an interesting thing to look at. And the other thing I think would be interesting to look at is whether or not people who subscribe to different positions at that highest level, so disagree with each other, might agree at some operation or case-based level. So I'm drawing here on Sunstein's arguments about incompletely theorized agreements, for example. But I think we could look at that empirically with respect to societal values and priority setting. So I'm just going to leave with these on the screen, if you like, as points for discussion, but there might be many more. And I'll leave it there. Thank you very much.
Thank you. Can I invite Sally to pop up a response?
I've still got this one.
This is made for men. You know, the way they button their shirt, it's made for men. That's what. Right, is that okay? Can you hear me? Thank you, and I'm really pleased to be here, and thank you very much for the conference organisers for inviting me, and I'm sorry to give them a scare by not arriving until about 10:05. I had a very nice walk along the canal, but it was somewhat further than I thought. So I was pleased to be here to hear the presentations, although I had sight of them before. Well, first of all, to say nobody said anything with which I can disagree, and possibly I could stop there. But I suppose what I'm going to reflect upon is where does it get us in the real world of NHS decision-making in terms of changing services, decommissioning services, commissioning services, closing hospitals, etc. So, Angela talked about changing the terms of debate, and I don't think she's wrong there. But how realistic is it to change the terms of debate, particularly given, as Rachel was talking about, the plurality, you know what I mean, of views that exist. And I suppose what I'm going to reflect on for a few minutes is sometimes it's not just plurality, sometimes it's contradictions, which is much easier to say. Contrary to the tenets of philosophy, I do think it's possible to hold two contradictory ideas at the same time. I find myself often doing that, I have to say. And out there in society, I think, there are, as we've heard, there are a variety of values, views, opinions, because society is made up of a lot of individuals, and all of those individuals may hold very different values and views and opinions in certain circumstances, which will be different in other circumstances. So it's very, very complicated. So I'm just going to sort of give a few examples of what I see as contradictory ideas. I'm then going to talk about a few contradictory messages which the system sometimes gives out, which I don't think is helpful in terms of changing the terms of debate and getting us to a new place in decision-making. And then finally, I'm going to reflect very briefly on what is commonly called patient and public involvement, patient-public voice, patient-public participation. The names change, which is what we're talking about, what Rachel was talking about, what Angela was talking about, involving people in decisions, and how I'm going to talk about how it happens or doesn't happen in the NHS. I've used nearly half the time already, so I better get cracking. Right, so some of the contradictory ideas out there. People do understand that we can't fund everything in the NHS, but they also don't understand that. The work that I've been involved with Justin and others about decommissioning services, there is a strong feeling among certain sections of society that actually we could fund everything. Little bit more tax, we could probably do it. And recently we had Dan Coulter, who was a health minister, an MP, who's a hospital doctor, suggesting a new tax for the NHS. There may be some value in that. It may help people to understand, explicitly how much of their taxes going to the NHS. But I think people often support that idea from a view we could actually fund everything. It would be perfectly doable. So sometimes there's an understanding we can't fund everything. Other times I think there is a genuine feeling that we probably could if we had the will to do so, and we don't need to make these difficult decisions. Secondly, I do think there is a difference, and we have heard about this already this morning, when people are talking about their own health and when they're talking about spending money on other people. And actually, quite often, they're prepared to forgo things themselves, particularly if they've had the benefits or disbenefits explained to them. But when you're talking about potentially not funding services for other people, sometimes there's a willingness to do that. People are seen as undeserving. We get, in the press, there are a lot of very unfortunate headlines about people who are seen as undeserving. But very often there's a feeling that people are deserving, but from the best in motives of people's heart that we should be providing these services for people. So again, it's often a contradiction between when it's for me and when it's for other people. Then finally, I'll just give, I had a few more, but I can do the time, just give one more, which is my favourite contradiction, actually, which is, my hospital is crap, but we must keep it open at all costs. which is, we see it in Mid Staffordshire as a case in point, the things that happen to patients at Mid Staffordshire, but the calumny that was heaped upon the heads of the protesters when other people thought that their hospital was going to be closed as a result of that. And then, is anybody here from Croydon? Anybody from Croydon? Right, no, all right. Oh, yes, well, there we go. What we must now learn to call Croydon University hospitals, Mayday Hospital, commonly known as Mayday. But please don't. No, in the press, public, that's what people called it, but we must keep it open. It's greatly improved, obviously, as is Mid Staff's, I hasten to add. So, there's contradictions out there, and, going on to sort of some of the contradictory messages that come out from the system itself, from the NHS, from politicians, from the newspapers, and just a couple of examples of that. How many times have you heard from decision makers in the NHS, the status quo is not an option? We've been hearing that where I live for the past 20 years about our district general hospital. We can't possibly keep it open. The status quo is not, it's not Croydon, a bit down the road from Croydon. Status quo is not an option. What have we got 20 years later? The status quo. It's still not an option, but we have still got it. So people sort of will not listen. In fact, if somebody's going to be lynched one day when they say that, because the public, recognise that is a message that's given out over and over again, and yet that's exactly what we get. We've had similar things about we must meet certain standards, called obstetric consultant cover, 24/7 obstetric consultant cover, and then suddenly, oh no, perhaps that's not actually necessary, but we still got to close this maternity unit because of some other standard which we've got to meet. And NICE, the government sets up NICE to help with priority setting and decision making, but people don't have to take any notice of NICE in certain situations. So, we recognise this body as making decisions, including societal values, etc. But as a clinical commissioning group, you don't actually have to take any notice of it unless it's a technology appraisal. So, contradictory messages given out. So, patient and public involvement. I know it's sort of what I do, what I've done for a long time. So, but on the other hand, the NHS is incredibly bad at doing patient and public involvement in a meaningful way. What we've heard about from Angela and Rachel is meaningful involvement. That is a world away from what happens in terms of service change and decommissioning. And, we talked about the STPs, Sustainability and Transformation Plans. Yes, there's been no involvement, meaningful involvement in those, right. But the only thing that makes me more angry or lose the will to live, depending on how I'm feeling, is than the NHS not doing patient and public involvement is when they do it, because it can be extremely meaningless and it gets us nowhere. So to conclude, I absolutely agree we need to change the terms of debate. I think the sort of methods we've heard from Angela and the sort of things we've heard from Rachel are about meaningful engagement and would help change the terms of the debate. But I feel very pessimistic in how that is likely to impact on how decisions are made by the English NHS in terms of the service they commission, decommission, hospitals that stay open, hospitals that close. So I'll finish there.